what I'm going to talk about is to look at the interaction of aging, chronic diseases, multimorbidity, and frailty. Multimorbidity is defined as basically a collection of chronic conditions that they are not necessarily interrelated. And we are going to review some of the gender impact. There's quite a bit of literature out there that the conditions that women and men suffer are not the same, and we need to understand that, research that, and also the effect of clinical approach. We're also going to look at how to support healthy aging. Obviously, as healthcare provider, we need to know that. We need to role model that to be able to advise our patients. And then how can we mitigate that and optimize the care? So I guess you all know, July 1st, 2015, for the first time in Canada's history, Canadians over age 65 outnumbered children under the age of 14. So that shift, that basically says we are becoming an aging society. Looking at the Canadian Community Health Survey, that was actually, the result was just published last year, the findings were that about 13% of Canadians, I lost my slide. So the single chronic conditions are more prevalent in younger population, although still 4% I have multimorbidity in younger population. However, as we age, we accumulate more chronic condition, hence multimorbidity. So that means our way of approach, treatment, and care for this individual ought to be different. Just disease-specific approach and management really does not work for our older population with frailty, multi-morbidity. I'm sure you're all aware of the aging demographics. If you look at it globally, we are all getting older, so that has definitely an impact on the pensioners and who is going to support them. I think it's very clear from these two pyramids that in the future we are going to have significantly higher proportion of those over age of 75, and as a result, frail elderly. So looking at Canada, actually the rise in those over age 85, they're going to be at least 24%. So this is something that we all need to be ready, the hospitals, the healthcare community, and the other way to also look at that, yes, we age, and there's a time you're born, there's a life cycle, and there's a way we die. And these are 4 ways of we die. Obviously, we all love to, have a very good active life, and then, go to bed and peacefully die. People with cancer, they tend to die this way. They reasonably have a good function, quality of life. In a short period of time, they deteriorate. And this is the way that most of the chronic conditions, such as heart failure, COPD, renal disease, that's sort of like a progressive, the trajectory is low, and periodic worsening, but they really never come back to their baseline. This is how individuals with frailty, multi-morbidity die. You just they're dwindling over time, does not have the same pattern. And looking at this slide, it basically frames the rest of my discussion. If you take a cross-section of the society. Majority of them actually are in those over age 65. They're living quite reasonably healthy and well. But as they age, they get older. Here they start to accumulate chronic illnesses, and these are the ones that actually mostly looked at by specialists, and when the numbers get higher, then start to impact body reserve ability to withstand stress, and about 5 to 10% of that population is frail with multi-morbidity, and at any one time about 2% of the population that they are in dying process at the beginning or end. Looking at chronic diseases across all the seniors and over age 65, it's interesting to see that hypertension and arthritis seems to be the highest level of chronic disease, and as you can see, arthritis more problematic in women. And now, if you change this graph to those over age 85, actually it changes. They're going to definitely see more dementia, more heart failure, but that's in basically all lumped together. We all know the healthiest way of aging is to be rich, and those from low socioeconomic status, they have higher hypertension, higher arthritis, COPD, diabetes, and heart disease. And as you know, our government spends twice as much on health care and in comparison to the social care, social programs, which obviously social determinants of health has significant impact in the number of chronic conditions. So aging is the strongest predictor of multi-morbidity and frailty. Let's start from the beginning. These are start with our hardwire or genes, followed by inflammation, inability of the cells to repair themselves. We lose mitochondria, which is the motor engine of the cells. Our lifestyle and our environment affects our gene expression or phenotype. Telomere, which is important in cell division, start to shorten. Impaired signaling between the cells and loss of stem cells. So this sounds like, okay, universal, it's going to happen. But the good news is actually recent literature shows that your lifestyle and the way you look at your own health does impact the software or the clinical presentation. So that's something to be aware of and work on it. Then you have, following the basic aging, then you have system-level conditions, cardiovascular, respiratory, and so on. And then you start to develop multi-morbidity, and these are, as I said, conditions that are not necessarily interconnected. And then what do we have at the end is frailty and susceptibility to poor health outcomes, quality of life. It's all about quality of life at that stage, more disability, functional impairment, issue of polypharmacy. They become higher user of hospital and health care, and obviously higher risk of mortality. In this slide, what it shows is basically, according to index condition, you have different rate of chronic diseases. For instance, purple is more than 5 chronic conditions associated, let's say, with depression. So when you go down the list, you see that progressively the number of chronic conditions increases. Heart failure, for example, is really a perfect storm, has the highest number of chronic conditions. And we already know that most of the patients that they come to the hospital with heart failure, at least 50 to 75% of them decompensated because of their other chronic conditions rather than primarily heart itself. Cynthia Boyd is quite a leader in research in multimorbidity, and it really gives a nice glance of people who are living with multimorbidity. And we need to understand that. Here's a life of someone starts with number of medication they are taking at different time, their diets, being salt and water. They have to check their sugar, their blood pressure. They have to do exercises that likely is restricted because of their chronic condition. Footwear, they have to avoid alcohol, watch their weight. They have to have, all kinds of visits to the doctors for measurements, for vaccine, for blood work. So it's really a handful. So it really doesn't leave a lot of time for actually living life. All you're doing, you're just chasing around those management of chronic condition you have. So that's not the best story. How can we then try to minimize and improve that kind of an outcome? Well, maybe we can start by looking at successful aging and look at those who have been a role model for that. Obviously, none of us, we can compete with the fame and fortune and the power of the Queen, but when you look at her lifestyle, she's very active, not only physically, mentally, she's socially engaged. There is not 1 minute of boredom in her life. So these are the foundation of a successful aging, the functionality, mobility, cognition, and community engagement. So if we know this is what are the pillars, the question is are we as providers doing it, and are we teaching our patients? On the other hand, frailty is a very peculiar, awkward situation that they are quite vulnerable. They have limited physiological reserve. Even a minor stress can tip them over and they will have poor health outcomes. So these are the two ends of that spectrum. Frailty itself is a spectrum, and that's what we need to recognize. Frailty is actually dynamic. By the spectrum, we mean that one starts with a state of vulnerability, then progresses to become more pre-frail, mildly frail, moderately frail, and severely frail. So seems to be sort of like a progressive downward. Our role is they have to recognize actually many of these aspects of frailty are reversible. We can do things to bring back to, if their baseline was pre-frail, and now in our assessment they are mild or moderately frail, there are things we can do to bring them back to their pre-frail state. So appreciating this dynamic spectrum is important even for our management. For instance, medication that you would give to someone at this stage could be completely inappropriate for someone who is in moderate and severe stage. Actually, not only is it inappropriate, it's harmful. And this is how we need to look at literature and apply those treatment, investigation, and interventions. I'm sure you're aware, obviously, there are many, many tools on assessing frailty. Fried in 2001 defined it phenotypically based on these 5 features. Clinically quite appropriate. You can just by talking and looking at people, looking how they walk, their sense of exhaustion, energy level, they're slow, have been losing weight, they have low activity level, they're weak. Based on that, you can say, okay, which one is not frail, means none of those characteristics, or which one is frail. The one that I particularly like and more practical is actually a functional scale. And, Rockwood published that in 2005. And I'm still surprised that, I have trainees or even we as professionals, when we communicate with each other, we have not incorporated this language in our day-to-day practice. So how does it start? Stage 1, you're basically robust, active, no problem. Stage 9, you're terminally ill, high risk of death, and then whole different layers in between. Here, as far as vulnerability is, people that who have slowed down or have mild cognitive impairment, they are already at this stage. And that's the type of patients that we do see them as an outpatient or the patient that have been admitted with acute illness. So if they're stage 4 at the beginning, that baseline, that's 1 month prior to admission where they were. And then when we assess them, they could be 6 or 7. And all we do as a geriatric team is to help them out to make them back to where they were. And that will be our aim. Unfortunately, when you look at literature, the type of patients that I was talking about are not really well represented in their study, only 9%. While in practice, general practice out there, frail elderly of different spectrum, at least 40% of the population. So there is a knowledge gap, and we are not even incorporating the latest research into our practice in relation to this population. So we all appreciate that we need to provide practice care for the population, particularly frail, that is based on their preferences, values, because as we discussed, maybe we don't have all the literature or all the best evidence. So then how do we care for them? The guiding principles is their patient preference and values. And then we do need to look at their life expectancy. So we have to use tools that helps us to appreciate, if somebody is going to be around another 5-10 years, because your treatment options could be completely different. That someone is going to be, life expectancy less than 3 years. And many of the medication and intervention is very inappropriate for them. And as I said before, quality of life is the cornerstone for this type of patients. Now, in general medicine, basically the way they look at these patients is based on the number of chronic illnesses they have. However, in geriatrics, in addition to all this, what we look at are the geriatric syndrome, their cognition, polypharmacy, frailty, falls, incontinence. So that basically summarizes the whole package of geriatric care and approach to individuals in frailty. So let's review some of the healthy aging issues. I mean, diet and lifestyle is really up there, right? Unfortunately, at the general population, maybe, the population becoming heavier and more obesity is a bigger problem. In geriatric population, actually, weight loss is a negative clinical indicator. So whenever we come in contact with our geriatric population, we must ask them if they have had weight loss. We must ask them is how their appetite now. The literature shows that if we follow proper diet, and I think most of you would know, you have heard about Mediterranean diet, nuts and olive oil improves your health. Actually, the mortality likely will decrease by 5%. So that's pretty impressive. How about gait speed in relation to healthy aging? Again, quite an impressive data. The faster you walk habitually, more likely that you are going to be living longer. And if I may, highlight here, Dr. Molnar, Kelly, they are a fast walker, so they're going to live longer than the rest of us. We better pick up the pace. Ladies, window shopping is not the kind of a pace you want to walk. You want to walk as if you are really late for your meeting. That's the speed that will extend your life. How about looking at healthy behavior and influence on aging? This publication at CMAJ was very interesting because it had data over 16 years. People who did not smoke, consume moderate alcohol, were physically active, eating lots of fruit and vegetable daily, they had 3.3 times odds of successful aging. So that's very impressive. This is a linear correlation. So we should be doing that, and also we should be telling that to our patients. This publication at BMJ last year looks at energy consumption, in other words, exercise, intensity of the exercise, and chronic diseases. So what you see is that the more physically active you are, met over 4, if you're just sitting on a day-to-day, you're consuming, that's your basal metabolic rate. So you really want to be higher than this. You want to be more vigorous in your activities. If you're active, the risk of ischemic heart disease significantly comes down. The risk of diabetes significantly comes down, as well as, colon cancer, breast cancer. So physical activity extends life through this kind of means. There are some good news. It seems that something is happening out there that over the last 20, 30 years has impacted decline of some of this chronic condition. For example, we had data that, the tsunami of dementia, which is true, dementia is a big problem in geriatric population. But comparing to the 40 years ago, actually, the incidence is going down, and they were both in at New England Journal of Medicine and JAMA publications. So that's very impressive, that maybe because we are doing better treatment of hypertension and diabetes. Definitely heart disease is coming down over the last 30 years, quite impressive. Heart failure mortality, 30 years ago, if you have heart failure, your risk of dying first year, it was 75%. But now we know that our heart failure patients are living much longer. Colon cancer, gastric cancer, diet-related, significant decline. Serious falls and fracture rates are coming down. And again, these are new data, but that means we are doing something right, that those intervention at population level, management of falls, risk reduction, osteoporosis, does work. There are fewer strokes. On the other hand, it seems that subdural hematoma is going up. And the question is why? So we have few strokes. How are we having few strokes? Because we are using, let's say, anticoagulant. But on the other hand, subdural is going up. Could it be that we are using warfarin or other oral anticoagulant in a wrong type of patients? There is a good argument that for moderate to severe frail elderly, actually, or practice needs to change, and those people are the benefit versus harm. The scale has tipped toward more harm, and we do need to incorporate this new data in our practice. Here I want to highlight the impact of our social engagement and also the culture of the community that we are living. Island of Sardinia has been quite studied by sociology, and they really find that in communities that their attitude toward aging is more positive. An older individual remains always part of the family life. They always have roles one way or another to play, even to quite extended age. They live longer. They have 10 times the number of people that they are living over age 100. Unfortunately, in America, there are issues of ageism. Did you know that 1/3 of the older population in North America have nobody to talk to on a day-to-day basis? So that's completely different way of social structure and culture. We are going to briefly touch based on some of the gender differences, because it's clearly we do not experience this disease the same way, and there is a need for research and clinical medicine. We know, yes, currently women are living longer. However, the quality of that years that they are living longer is not that great. They have a lot of disability, a lot of mood disorder, and they're functionally dependent and more likely to be living alone. Cardiovascular disease still remains the leading cause of death, but on average, you ask a woman, what are you afraid of dying, is a breast cancer. Multimorbidity is more common in women. Sensory and mobility problem more common in women. They are more consumer of our hospital system. On the other hand, good for men, they are enjoying 7 years more free of chronic illnesses. And on average, men tend to have a more positive attitude toward the state of their health, which is good, and is something that maybe women should start to learn. If you're a woman and you have MI, the risk of death is much higher comparing to men. Why is that? We are all aware of obstructive coronary disease. If you look at the blood flow in the coronary, when here's an obstruction, the blood flow drops. So what do? You put a stent, you bypass it, and great. And that works quite well in men and maybe 60% of women. But the rest of the women, they have this condition, which is narrowing throughout the coronary. So the blood flow is sort of trickling down. And how do you treat that? We even haven't studied it properly, how we treat this condition, because most of our research and attention has been about obstructive coronary disease. How about dementia? This is from Canadian Study of Health and Aging. Proportionally, there are more women with dementia. Is it that their brain is more at rest developing Alzheimer's disease, or is it just because all the condition related to the living longer remains to be seen? But we know that women, they are more at risk of silent brain infarct in comparison to men. So maybe this plays a big role in dementia in women, and something that we should be targeting, maybe microvessel disease that causes a silent brain infarct, ought to be targeted more aggressively in women. In relation to falls and injury, maybe women, they don't have enough muscles, they are not physically enough active, they are falling more, and they have more injuries. Heart failure. You all heard about heart failure with preserved ejection fraction. 10% of those over age 65 have HFpEF, this condition, but that significantly increases for those over age 85, which again, a lot of them are women. Here, you have systolic heart failure more in men, and then you get a shift with aging, you have more women with heart failure and with diastolic failure. So here, where geriatric particularly can play a major role in collaboration with primary care physician and cardiologist. So there are now few considerations in the frail older individual. Let's talk about hypertension, diabetes, polypharmacy, frailty, and osteosarcopenia. So if your patient is within this age and has hypertension, and you want to start them on antihypertensive, the benefit of MI and stroke prevention outweighs the harm. There is still risk of falls, but this benefit is very impressive. So obviously you're going to treat. However, if you belong to this segment, the one with chronic illnesses getting to frailty, multimorbidity, suddenly you see, wow, falls becomes actually a major problem. So how do you make that decision? This is why our targets for treatment of hypertension has changed. How about diabetes? Risk of dementia significantly goes up in diabetic management, particularly with insulin, something that we don't pay much attention. The number of hypoglycemic episodes, the more it is, there's more risk of developing dementia. That's quite impressive, and this is why, again, we are really worried about hypoglycemia, and our targets for both blood pressure management and diabetes has changed. We aim for hemoglobin A1C for our frail older individual less than 8.5, we are happy. We want, perhaps glucose range when we are monitoring to be something between 7 to 12 or 8 to 12, but not less. Or for blood pressure, we want, a target that is perhaps less than 150 or 140, maybe it's even a better number. So in polypharmacy, they have the chronic conditions, they're seeing lots of doctors, they're seeing lots of pharmacies. And many of us as physicians, we are quite reluctant to stop drugs. And we also have not yet really looked at the literature more critically. Number needed to treat, the benefit versus number needed to harm. I really want to emphasize for those moderate to severely frail, the harm of some of the medication we are giving is by far more than the benefit. Last year, there were just 3, major publications on statin. Cochrane review. We should not push statin on this type of patients. Looking at atrial fibrillation, again, people with multimorbidity and moderate to severely frail, their risk of injuries or harm with oral anticoagulation is higher. So maybe we should not be pushing for that. A list goes on and on. I mean, look at PPI. Many of our patients are on PPI. Good 30 to 40% of them, there's really no good reason to be on PPI, and we don't question it, we just continue to order it. And PPI, there's significant list of complications, such as C. difficile. So there's a lot to absorb, I know, but that there should be a very serious justification for any medication we are giving for that population. So now I want to talk about osteoporosis. Sarco being your muscles and bone. Health of your muscles, health of your bone determines your function, your mobility, risk of falls, hip fracture, and loss of functional dependency. So if this is a normal bone, and this is osteoporotic bone, we all know that. But look at the muscles, with aging. Unless from midlife, we continuously do resistance training, our muscles are going to be replaced with all kinds of fat, okay? Even if the size doesn't change, the muscle has shrunken. Why is that? The origin, the stem cells that make your fat or cartilage or bone, muscle, neuron is the same stem cell. What happens with aging? Your stem cells produce more fat cells. If they are not stimulated with your lifestyle, it's going to make less muscles and less bone. And we know we can prevent that. And maybe even we can reverse that. So the key message here is that for healthy aging, for both gender, we need healthy muscles and healthy bones to prevent frailty and improve our lifespan. So how do we move forward? This is where geriatric services primarily are focusing on. Primary care physicians here, many specialists. Likely with many specialists, we need to partner maybe through programs, partnership programs, and closer relationship. But here is where the pink is where we basically in practice on a day-to-day basis as a team. These are the kind of patients we look after. So where do we go from now? We know that that type of patient, actually up to 60% of patients that they come in acute care hospital have moderate to severe frailty. You see, I'm not necessarily saying aging, because one obviously could be, a young elderly or midlife and be severely frail. But this is the population. So the frailty is really a good start as far as, getting your programs, your focus into helping these people, one, stay out of the hospital, or if they are in the hospital, to be in the hospital for the least amount of time, and developing outpatient program to keep them out. Now, these are your, there are many broad brush or umbrella type aims. One is quadruple aim, better care, better outcome, better value, and provider wellness. And it used to be triple aim, now it's quadruple aim, because they realize if you really want to keep your population well, you have to look after your providers, healthcare providers. When they are burned out and stressed, they are not at their best. We know that, our division is adopting 5M, and then the question I have is is provider wellness is part of that, something to think about. The other issue is that do we all really need to bring all these very frail people to a unit or create a sort of a more like a very specialized unit? Or should we really take these principles of geriatric care throughout the hospital? Frank always talks about taking geriatric to the patient. I think it's a very good comment. So this concept of gerontologizing the rest of the hospital at the level of education, screening, early intervention by geriatric teams is quite important. The reality is you're never going to have enough doctors that are geriatrician. We are right now only 0.3% of the doctors are geriatrician, and so we really have to look at how, with these limited resources, how we can develop the teams, or nurses that they can be more specialized and take the tasks on gerontologizing the rest of the hospital or out there in community, for example. So we have to really think of new ideas. So what does it look like? So here is like a deer in a headlight, it's coming. So we have to be in a position to know that this group of patients, as I said, moderate, severe, frail, they are coming, they're going to be in our hospital, they're going to occupy our beds. That's why our emergency rooms are overcrowded. And so we have to have a plan, and that needs leadership. And I recommend that you go to commonwealthfund.org. They have 10 recommendations that is quite meaningful and basic, and is a starting point. And we really need to this is the language we need to be talking in doing assessment and treatment. And I want to finish with, they're looking at frailty strategy that should be hospital-wide to serve frail patients, because they're transitioning through all kinds of services in our hospital. And I apologize if I talk about hospitals so much, because my practice is this way. So the lens I look at the care is through hospital. But so the strategic direction need to be toward understanding frailty, building a common language around it, engaging the stakeholders, understanding patient experience, their needs and wants, and be better in using IT and communication. There are already enough literature there that we do need to translate that into practice, and we should really not engage in anything new that we are not already measuring it, researching it, evaluating it, because I believe that the key success factor is not only awareness, education, and branding of the frailty in order to get attention of senior management, but also to use quality methodology for any new activities we do, that it should have patient, provider, and process metrics to be able to evaluate that, and also look at how we can sustain it, and what kind of help the hospital or senior management can give to us. So this is the end. I apologize, it took a bit longer. I wanted to really put more time for interaction and question. Thank you.